Okay, this is video 18. Video 18, guess what this is about? Breathing muscles. Okay, so what are we talking about today in video 18? We're talking about the diaphragm, right there. We're talking about the intercostals. There are some, and there are more intercostals. We're talking about serratus posterior superior here, serratus posterior inferior here, and what else? Sternocleidomastoid here, and the scalenes in here. That's one of them anyway. There's another one, scalenes, and the hyoids, which are in here, which is a whole group. They're down in here. Okay, so those are the muscles we're talking about today. The diaphragm, the intercostals, serratus posterior superior, serratus posterior inferior, the hyoids, the scalenes, and sternocleidomastoid. So the hyoids, they are a little bit of an exception to this group because they're not as much breathing muscles as the rest of the muscles are that we're talking about today, but the rest of them are breathing muscles. So one of the things about breathing muscles is they attach to the rib cage, which makes sense, right? Here's the primary breathing muscle. So let's go ahead and get started. We're going to get started with the diaphragm. The diaphragm is the primary breathing muscle. It is right here. It is kind of an interesting looking muscle, isn't it? When you look at it like this, does it kind of remind you of, did you ever in gym class in grade school play with a parachute where all the kids stand around the outside of the parachute and you flutter it up and flutter it down and it makes this big sort of mushroomy shape and you can get inside of it and stuff? That's kind of what the diaphragm looks like, I think, if you take a look at it. So where does the diaphragm attach and what does it do is the question. So the diaphragm attaches all around the outside of the thorax, essentially. So the diaphragm separates the thorax from the abdominal cavity. So its attachments are the internal surfaces of the rib cage, the sternum, and the spine. So if we want, well, let's just look at it instead of getting all detailed. Let me add on connective tissue so we can see the costal cartilage. Okay, so we can see that it attaches to the xiphoid process, right? Can you see that? Let's get a pen out here. Right there, it attaches to the xiphoid process of the sternum. And it attaches to the inner surface of the costal cartilages in through here on both sides. And then it attaches to the ribs down in through here. So these lower few ribs it attaches to. Here, 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 it's attaching to ribs. And then if we look inside here, we can see it attaching to the bodies of the lower thoracic and upper lumbar vertebra in through this region here. And even, you know, see how it kind of has these little parts that reach down to get a good solid purchase on the bodies of the lumbar vertebra. So so that's the origin. So that's where the muscle attaches. Those are its bony and cartilaginous attachments. So where does it insert? Where does it insert? Well, it inserts, strangely enough, on itself. So this is its tendon right here. It's called the central tendon. And so what that means for this muscle is we have tendon around the outside at all of these bony and cartilaginous attachments, and we have tendon around the inside at the central tendon, and then the muscle fibers all kind of go around in a way kind of like spokes, even though it's not a nice circular wheel, but you can sort of think of it as the fibers as spokes of a wheel. So what happens with this muscle How does the diaphragm work is the question. So the lungs, if we add on the lungs, what we see the nice pink lungs in there. Let's fade other things here, see if we can get a good, I don't feel like that gives us a good view of the lungs. Anyway, so the lungs are the pink inside there, but as I indicated, it turns green. Those are the lungs inside the rib cage, right? So the lungs are covered on the outside with a membrane called the pleura. That pleura is attached to the inside of the thoracic cavity. So inside the ribs, let's make the lungs go away here again. So inside the ribs, the lungs attach in there, and to the top of the diaphragm. So I guess like this would be the view that the lungs have of the top of the diaphragm. So the way that breathing works is that, so what you're looking at now is the diaphragm in a relaxed state. When the diaphragm contracts, when we breathe, the fibers all shorten, and when the fibers all shorten, the result is that the central tendon lowers. So the diaphragm is kind of a big arching thing like this when it's relaxed, and when it contracts, it flattens and lowers. So when it lowers, it pulls down on the lungs, essentially increasing the size of the lungs. So if we remember Boyle's law, we remember that if we have a gas is at a certain pressure and at a certain volume, if we increase the volume, the pressure of that gas is going to decrease by the same amount. And so what we're doing by increasing the size of the lungs, by lowering the diaphragm, thus increasing the size of the lungs, we're lowering the pressure inside the lungs, the air pressure inside the lungs. Once we get that air pressure inside the lungs lower than atmospheric air, the atmospheric air naturally wants to go into the lungs to where the pressure is lower. So that's how an in-breath happens. So give that a try. Well done. Okay, so now the question is, how do you do exhalation? So inhalation is the active part, right? That's the active part of breathing. The diaphragm is active on the inhalation. On an inhalation, the diaphragm contracts, it lowers, which increases the size of the lungs, which decreases the pressure in the lungs, which pulls atmospheric air into the lungs. The exhalation happens just with the elastic recoil of the lungs. So we're not really looking at the lungs right now, but there they are. So inside the lungs, and we can't get a super good view of the lungs here, but let's pretend we can. They're all these little alveoli, and the walls of the alveoli have elastic fibers that are part of the connective tissue that makes up their wall. And so when we inhale, when we increase the size of the lungs, which pulls air into the lungs, those elastic fibers stretch. And then when we relax the diaphragm, then those elastic the elastic fibers naturally recoil and return to their original size. So it's the elastic recoil of the lung tissue itself, or within the lungs, that presses the air back out again. See how close the top of the lungs, the apex of the lungs, are to rib 1 up there. Anyway, so that's breathing. Inhalation, the diaphragm is active. The diaphragm descends, that increases the size of the lungs, which decreases the pressure in the lungs, which pulls atmospheric air in. The increasing of the size of the lungs stretches the connective tissue in the lungs, the elastic fibers specifically, and then they recoil and push the air back out for the exhalation. So that's a normal quiet breath. So a normal quiet breath, all we really need to use is the diaphragm. But for a lot of breathing, we use a lot more than the diaphragm. Let me just say a couple more things about the diaphragm before we move on. So if we look down here, there we go, we should be able to see 3 holes in the diaphragm. We see a hole here, we see a hole here, kind of missed it, and we see a hole there, okay? Each of those is called a hiatus. A hiatus just means a gap or a break in the diaphragm. So this hiatus right here is for the abdominal aorta. So the aorta is the big blood vessel that is taking oxygenated blood out to the body. So that one is really deep in the body and very well protected. So it's right in front of the spine. This hiatus right here is for the inferior vena cava, which is taking deoxygenated blood from the lower body, from like the intestines and the organs in the abdominal and the pelvic cavity, but also all of the muscles of the lower extremities, up to the heart to head out to the lungs to drop off its CO2 and pick up more oxygen. So that's the inferior vena cava that's going through that hiatus. And this one right here is for the esophagus. So the stomach is nestled right underneath the diaphragm. And so, of course, we need to have a place for the esophagus to pass through, because the esophagus is above the diaphragm and the stomach is below the diaphragm. So anything that needs to pass through from the thoracic cavity to the abdominal cavity has to get through the diaphragm. So that's why we have those holes there in the diaphragm. Other than that, the diaphragm makes a pretty solid barrier between the thoracic cavity and the abdominal cavity. All right, so diaphragm, primary breathing muscle. Its action essentially is to lower. It lowers. What does the book call it? Let me see. Action. It increases the volume of the thoracic cavity via abdominal breathing. That's its action. Okay, that's what I said more or less, right? All right, let's get rid of the lungs. Next, we're going to move on to accessory breathing muscles. Accessory breathing muscles are muscles that move the rib cage. So with a diaphragmatic breath, the diaphragm moves, and you can do a diaphragmatic breath that is just the diaphragm, although that doesn't happen all that often. But people who use their voice professionally, people who sing and who act and learn to use their voice and their breath correctly, learn to breathe with their diaphragm, because it's the correct way to breathe. However, taking a big deep breath requires more than just the movement that happens in the diaphragm. So most of our breathing is primarily the diaphragm moving, but bigger breaths require more movement of the rib cage. So let's talk about the intercostals. So the intercostals are muscles that are between the ribs. That's exactly what their name means. Inter means between, and costals refers to the ribs. So there are two sets of intercostals. We have these guys here, which are the internal intercostals, meaning they are the deeper layer of the intercostal muscles. The internal intercostals do not go all the way to the sternum. So you can see this gap here between the rib and the sternum for each one. So they occupy the posterior 2/3 of the rib cage. The external intercostals, we need to put them on. Here are the external intercostals. They occupy the anterior 2/3 of the rib cage. But same thing, they're still called intercostals. They are between the ribs. That's what their name is telling us. They occupy the anterior 2/3, so you'll see that they don't quite go all the way to the spine back here. So there's kind of this gap back here. But all in all, with all of the intercostals in place, the rib cage is pretty covered. Of course, it is mostly covered, or where it has two layers is this middle 1/3 of the rib cage. That's where there are both internal and external intercostals. So let's take a look at what the intercostals muscles are doing. So essentially, they both attach between ribs, so that both the external and the internal intercostals attach to the lower border of an upper rib and the upper border of a lower rib. And they just span between two ribs like that. So action-wise, it's a little, this would be getting a little nitpicky to get all the way into it, but I'm going to just tell you this anyway. So the external intercostals, their standard mover action is elevation of the rib cage, or expansion of the rib cage for inhalation. Their reverse mover action is depression of the rib cage, or compression of the rib cage for expiration or exhalation. So so basically, you know, we know that there is a standard mover action and reverse mover action for any muscle. And so basically what this is telling us is that the external intercostals can both lift the ribs for inhalation and compress the ribs for exhalation. So now if we look at the internal intercostals and look at their actions, we're going to find the exact same actions in reverse. So their standard mover action is depression of the ribs or compression of the rib cage for expiration or exhalation, and their reverse mover action is elevation of the rib cage or expansion of the rib cage for inspiration. So what that means is they both really can expand the rib cage and compress the rib cage. So, but you know, officially, the external intercostals, their action is elevation of the rib cage for inhalation. So the external intercostals do inhalation, the internal intercostals compress the rib cage or depress the ribs, and so they help with exhalation. But they both do both in reality. Okay, so those are the intercostals. So if you take a big deep breath and really try to expand your rib cage, you know, it's funny because we talk about breathing like that. Take a deep breath, expand your rib cage. But really what we're doing is, if we're going to take a deep breath, we first expand the rib cage, and it is the expansion of the rib cage that allows for the breath. But let's do it. Take a deep breath, expand your rib cage. So feel how much your rib cage moves, how much it can move. Of course, you know, these are bones and there's cartilage and there's joints, but they don't move a lot, but they move some. And that movement that they do moves the lungs enough to expand the lungs to allow more air in. And now if you do a strong exhalation, and really try to compress the rib cage, you can feel your rib cage kind of compressing, getting, you know, the whole thing gets kind of tighter and smaller. And so that's helping the elastic fibers in the lungs to push out some more air. Okay, so we have the diaphragm, which is the primary breathing muscle, the external and the internal intercostals that are secondary or accessory breathing muscles. Now we have more, and those are kind of, oftentimes that's kind of the end of the story when we're talking about breathing muscles, but really there are many more muscles that help out with breathing. And really almost any muscle that attaches to the rib cage, we could call it an accessory breathing muscle. We're going to look next at these serratus muscles in the back. So serratus posterior superior and serratus posterior inferior. So here is serratus posterior superior. Here is serratus posterior inferior. So these muscles attach to the spinous processes. I am just going to find them in the book real quick so I can tell you exactly which spinous processes they attach to. So serratus posterior superior attaches to spinous processes of C7 through T3, in through here, C7 through T3. That's serratus posterior superior, so let's indicate that one. And then it's going to go to ribs 2 through 5. Okay, so rib 2, 3, 4, 5. Okay, so that is serratus posterior superior. So what does that muscle do? It elevates ribs 2 through 5 for inhalation. So it helps to expand the rib cage. So when we're taking a deeper breath and we're really expanding the rib cage, serratus posterior superior is one of those muscles that helps to expand the rib cage to create more space for the lungs so we can get more air in there. Serratus posterior inferior, however, kind of does the opposite action. So serratus posterior inferior attaches to the spinous processes of thoracic vertebra 11 and 12, and then lumbar vertebra 1 and 2. So right in through here. And then it attaches to the lower 4 ribs, so 9, 10, 11, and 12. So we see that here, 9, 10, 11, and 12. So serratus posterior inferior, what it does is it's going to pull down on those ribs, on those lower 4 ribs, when we're compressing the rib cage, so it's going to help out with exhalation. Okay, so those two muscles, serratus posterior superior, helps out with inhalation. Serratus posterior inferior helps out with exhalation. Okay, let's see. What else do we have as far as breathing muscles go? We have the hyoids, which are not exactly breathing muscles, but let's go ahead and talk about those guys. So the hyoids, what are these guys all about? All right, the hyoids as a group, there are actually two groups. There are suprahyoids and infrahyoids. So let's actually start this conversation with the hyoid bone. So the hyoid bone is this bone here that does not articulate with any other part of the skeleton. So it's this kind of this floating bone here. So no joints, no articulations for the hyoid bone. It's like this floater there. So what's the hyoid bone do? Why is it there? The hyoid bone is there because the base of the tongue attaches to it. And since it does not articulate with any bone in the skeleton, we need to have a lot of muscular attachments there to stabilize it so that the tongue has this stable place to come from for all of its movements. So that's what the hyoid muscles do. So there are two groups of hyoid muscles, the suprahyoids and the infrahyoids. The suprahyoids, as their name implies, are above the hyoid bone. So here's one of them. It's called mylohyoid. And so almost all of the hyoid muscles attach to the hyoid bone because one of the key functions of those muscles is to stabilize that bone. So the suprahyoids attach to the upper part of the hyoid bone. So that is one of them, mylohyoid. Let's see. Here's another one, digastric. Digastric actually has two bellies. This is the anterior belly. Here's the posterior belly. So there's two parts to digastric, or digastricus. Whoops, that's hiding them. Let's see more here. I'm not sure if we're going to be able to see more. That is not a hyoid muscle. Okay, so I know that we can see another one or two in here, but anyway, but I don't remember what layer they're on and how to see them. Yeah, no, that's not a hyoid. And that's digastricus. Okay, well, let's go on to the infrahyoids. Let me see. Hyoids are on page 242. Let's just name these guys here. So we have mylohyoid. These are the suprahyoids. Mylohyoid, digastric, so those are the two that we could see. We have stylohyoid, that goes back to the styloid process of the temporal bone. And what is the last one? Geniohyoid is the other suprahyoid. So the suprahyoid muscles, what they do is they stabilize the hyoid bone from above. Okay, and so you can see also, you can see mylohyoid, that it attaches to the inside part of the mandible in through here. And so the other thing that the suprahyoids do is they depress the mandible. So when we were talking about the muscles of mastication, we saw all these muscles that elevate the mandible, right? Like temporalis and masseter and the pterygoids. There's a lot of lateral deviation in those muscles, protraction and retraction in those muscles, and elevation in those muscles. And those four that I just listed, temporalis, masseter, and the medial and lateral pterygoids, those are considered the primary muscles of mastication. The suprahyoids are the only ones that depress the mandible, and so they are in a good position here to pull down on the mandible. So for instance, mylohyoid, if you can see, so the thing is, for it to be able to do that, the hyoid bone needs to be stable. But if the hyoid bone is stable, then mylohyoid can easily depress the mandible. So the suprahyoids depress the mandible, but they also stabilize the hyoid bone from above. The infrahyoids, let's look at these guys. So we have sternohyoid that goes from the sternum to the hyoid bone. We have thyrohyoid, which goes from the thyroid cartilage to the hyoid bone. We have sternothyroid, which is actually the only hyoid bone that does not attach to the the only hyoid muscle that doesn't attach to the hyoid bone. It attaches to the sternum and to the thyroid cartilage. And the last one is called omohyoid, and it is right here. And it also has two parts. It has this superior belly and this posterior belly back here. It actually goes all the way back to the scapula, of all places. So there's that right there. So you'll notice actually that omohyoid in the middle of it, I don't know if I can indicate this. Oh yeah, I can. It has a tendon called the intermediate tendon. And so why does omohyoid have a tendon in the middle of it? So, well, there's a reason for it. Because underneath that tendon runs a neurovascular bundle, and so to protect that neurovascular bundle from having too much pressure on it, we have a tendon there instead of the muscle fibers of omohyoid. So we'll talk more about that neurovascular bundle momentarily when we talk about the scalenes. But those are the hyoids. Anything else we need to say about the hyoids? They can do flexion of the neck when the mandible and the hyoid bone are stable. The main thing to know about the hyoids, though, is that the suprahyoids stabilize the hyoid bone from above. The infrahyoids stabilize the hyoid bone from below. It's important for the hyoid bone to be stable because that's where the base of the tongue attaches. So all of our tongue movements have a stable place to come from. So therefore, we utilize the hyoids every time we speak and every time we swallow, when we're using the tongue and when we're moving the mandible. The suprahyoids depress the mandible as an additional action, and the infrahyoids also do flexion of the neck. But primarily it's stabilization of the hyoid bone that's important with these guys. And also just sort of appreciation for the number of muscles that we have in the neck. So, that's a nice addition to our list of muscles in the neck, and we're about to add 3 more on here. So our next 3 muscles that we're going to talk about are the scalenes. So the scalenes are lateral neck muscles. There are 3 of them. We have the posterior scalene, we have the middle scalene, and we have the anterior scalene right here. Okay? So those 3 muscles are also really interesting muscles. Like, they're not very big. It doesn't seem like they would be a big deal, kind of like the hyoids. There are very few muscles in the neck that are very big. Some of the muscles in the posterior neck are big, and we're about to talk about a big primary mover in the neck. But for now, let's talk about these little guys, actually, because they're really important. So the scalenes are lateral neck muscles. So as a group, their attachments, and it's just fine if you just kind of know their group attachments. As a group, so all 3 of the anterior, middle, and posterior scalenes, will lump them together as a group and say that their attachments are the transverse processes of C2 to C7. And their insertion are the superior surfaces of ribs 1 and 2. So we can see that here, right? Here is posterior scalene. You can see its attachments on the transverse processes of the cervical vertebra, and then it's going down to rib 2. Here is the middle scalene. You can see its attachments to the transverse processes. It has quite a few transverse processes that it attaches to. It goes down to rib 1, and then anterior scalene, you can see its attachments here to the transverse processes, and it goes down to rib 1. So the scalenes are here in this group of breathing muscles because they attach to the ribs. So remember what I said, that almost any muscle that attaches to the ribs, we could consider it an accessory breathing muscle. And the scalenes are certainly in that group. So like for instance, let me just throw in here, we've talked about this guy already, pectoralis minor. It is an accessory breathing muscle. It elevates ribs 3, 4, and 5 for inhalation. So we've already seen this. We've seen some accessory breathing muscles that attach to the rib cage and expand the rib cage to help with inhalation or compress it for exhalation. So anyway, so back to the scalenes. So we had seen the intercostals attaching to all of the ribs and elevating and compressing the rib cage to help with inhalation and exhalation. The scalenes are attached to ribs 1 and 2. And so being attached to ribs 1 and 2, over here, they elevate ribs 1 and 2, which makes sense that we need to have muscles that are attached much higher up in the neck and then attaching to ribs 1 and 2 to be able to elevate ribs 1 and 2, because there's, you can't lift rib 1 without attaching something up above rib 1. So that's what the scalenes do. They are accessory breathing muscles. This is one of their actions. They're accessory breathing muscles, and they elevate ribs 1 and 2 for a deep inhalation. Other things that the scalenes do, when they're moving the head and neck, they do lateral flexion of the neck. So you can imagine this muscle here, that if it pulls laterally, that it will do lateral flexion of the neck. These guys also do a lot to stabilize the neck. And one of the times that scalenes really show up with pain and tension and problems is in the weeks following a whiplash injury. So in a whiplash injury, the ligaments of the neck, if they get torn or injured, then they are going to require 6 to 8 weeks to repair, because that's how long it takes for ligaments to repair. During that time, the scalenes do their very, very best to try to be like the ligaments of the neck, which of course they cannot be ligaments because they're muscles, but they try. And they try and they try and they try. And for a muscle to try to be a ligament, what that results in is that muscle getting tight. And so when the scalenes start to get tight, it will tend not to be an issue until weeks after the whiplash injury, because they'll do okay for the first couple of weeks trying to be ligaments, and then they'll start to peter out and they won't be able to last, through the whole repair process. So, but let's add on the nervous system here and arteries and veins. So now we begin to see some other aspect of the scalenes. So what I have indicated here is, the muscle I have indicated here is the posterior scalene. Just anterior to it is the middle scalene. Now, I don't know if I can zoom into here is the anterior scalene. So notice all of that stuff that is coming out between the anterior and the middle scalene. So we have, that's not actually coming out. That's the external jugular vein. It's not actually coming out from between there, but let's see if we can find some things that are. This is, so the subclavian artery runs through that space in between the anterior and the middle scalene. The superior, this is the superior trunk of the brachial plexus, but we could just say the brachial plexus, because I don't know if I can indicate the inferior trunk. I might be able to. There's the middle trunk, and that's the subclavian nerve. Anyway, so, but you can see all these nerves in here, and let's just look at the superior trunk of the brachial plexus. All of this stuff is coming out from the spine in between the anterior and the middle scalene. So if these scalene muscles get tight, and also here we can see omohyoid right here. Oops, not there. That's the tendon of omohyoid. And see how that nerve, it goes right under that tendon of omohyoid there. Okay, so this neurovascular bundle comes out from in between the scalene muscles. It goes under the clavicle, so we can see it going under the clavicle there, this whole bundle. So now the subclavian vein is part of this whole thing too. Goes under the clavicle, it goes under pec minor. This guy's pec minor right here. So it goes under pec minor, this whole big bundle. right, of muscles, not muscles, of nerves, of blood vessels that are both arteries and veins, go under pec minor through the axillary region. So here we're looking at the armpit-ish area, through the axillary region, and then down the arm. So, so this is the nerve and blood supply to the arm. And if it gets impinged either by a tight, overworked pectoralis minor or tight, overworked scalenes, we can start to have symptoms down the arm. And we'll tend to see that sort of thing often happening a few weeks after a whiplash injury. And it can happen other times too. Other times that it might happen are either with people with poor posture, where pec minor is pulling the scapula forward, and over time pec minor is shortening and shortening and shortening and putting pressure on that bundle. Or people with breathing issues such as asthma, or people who are smoking, or people who are having other issues with inhalation. So COPD, for instance. Well, COPD is more of an issue with exhalation, but breathing challenges. Those folks can have undue tension in these accessory breathing muscles like pec minor and the scalenes. So all of these muscles are accessory breathing muscles. All of these muscles are associated with this neurovascular bundle that's coming out from the neck, going through in between the anterior and the middle scalene, going under the clavicle, going under pec minor, and then going through the axillary region out to the arm. When this neurovascular bundle gets compressed for whatever reason, like for instance, like a broken or a subluxed clavicle can also be a problem, or a broken clavicle that doesn't heal well, that ends up with like a thickening of the bone in there. That's another thing that can put pressure on those nerves and those blood vessels. But when that's happening, symptoms that the person can have can be pain, numbness, tingling that goes down the arm. So it can mimic carpal tunnel syndrome, or the pain and numbness and tingling can be in the neck region, it can be in the shoulder, it can be anywhere down the arm. It will tend to get worse when the arm is raised overhead, and that's one of the tests that you'll learn in neuromuscular systems to test for a syndrome called thoracic outlet syndrome. So thoracic outlet syndrome is what happens when this brachial plexus gets impinged somewhere along the way, and scalenes and pec minor are the two most common culprits as far as muscles go for impinging that the brachial plexus. So that is a little bit about thoracic outlet syndrome. Very, very common. And sadly, thoracic outlet syndrome can often be misdiagnosed as carpal tunnel syndrome. So when that's the case, somebody might have surgery on their wrist to try to relieve the pressure on the nerve in the wrist, but really the pressure is up here, somewhere in the scalenes or in under pec minor or something. And so doing that surgery to relieve pressure in the wrist isn't going to make any difference if the pressure is coming from up here somewhere. But working these muscles absolutely will make a huge difference. So getting in there and working pec minor and releasing scalenes, which is not a pleasant situation necessarily for the recipient, but extremely effective and much cheaper and quicker relief than surgery, and more effective if the problem is up there in the neck. Okay, let's take some of this off. So that's a little bit about thoracic outlet syndrome. All right, we have one more muscle to talk about here, which is, I'm going to take off arteries, take off veins, take off nerves, get back to just muscles here, and we're going to talk about sternocleidomastoid. So sternocleidomastoid is our last muscle in this video. Sternocleidomastoid is named for its attachments. So its attachments are the sternum, the clavicle, that's the cleido part of it, and the mastoid process of the skull. So let's find those. So so it actually has two bellies, and so it has the sternal head or belly, and so it attaches to the sternum right here. So that's the sterno. Cleido, that refers to the clavicle, that attaches to the medial part of the clavicle there, and then the mastoid process of the skull, right? Let me do this, do that. We should be, now let's do it the other way. Let's fade the muscle, and then see we can see the mastoid process of the skull there. Mastoid process is, remember, part of the temporal bone. So that's where sternocleidomastoid attaches. Okay, sternocleidomastoid, big, strong muscle of the anterior and lateral neck. What is superficial to sternocleidomastoid? Nothing but platysma. And platysma is a super thin muscle that's just really considered a muscle of facial expression, so it's not, really a significant mover. Sternocleidomastoid is the main mover here. So actions the sternocleidomastoid can do, so it can do both flexion and extension of the head and neck. And so let's go back and fade this again and see how it attaches here to the mastoid go away for a second. Let me make it a little bigger. Okay, it attaches here to the mastoid process, which is right here. So it has fibers that are back here. It has fibers that are up here. So sternocleidomastoid, if these fibers back here attach and pull on the head is going to turn and face upward, right? So extension of the head and neck is one action of sternocleidomastoid. If these fibers here pull down, then the head's going to go this way, and then we have flexion of the head and neck. So here we have one muscle with opposing actions. Come back. All right, there it is. So we can do both flexion and extension of the neck, of the head and neck. It also can do, I don't think this is actually listed in the book, it can do it can do protraction of the head, which is this kind of a moving the entire head forward. So if we think about these attachments lining up more with these attachments, so if they line straight up and down like this, the head has to move forward in order for that to happen. So that's this, like sticking the head out like a pigeon does when it walks around. So that's protraction of the head. And sternocleidomastoid also does lateral flexion of the neck. So when one side is working, so those actions that I talked about before, those are all bilateral actions. If we look at a unilateral action, sternocleidomastoid can pull the head and neck down, so like ear to shoulder, so lateral flexion of the cervical spine. So that's sternocleidomastoid. But why is sternocleidomastoid here in this video with breathing muscles? Well, sternocleidomastoid, like its name tells us, attaches to the sternum and attaches to the clavicle. And so far, we've seen all these accessory breathing muscles that attach to the rib cage and help to either expand the rib cage or compress the rib cage to help out in accessory kinds of ways with breathing. What sternocleidomastoid does is it can pull up on the sternum and up on the clavicle to lift the sternum and lift the clavicle as part of this whole process of lifting or expanding the rib cage for inhalation. So sternocleidomastoid is also another accessory breathing muscle in its action of lifting the sternum and lifting the clavicle. And it does that for inhalation. Now, sternocleidomastoid, you should be able to palpate your SCM pretty easily. If you find your mastoid process, you should be able to kind of pinch it right up here between your thumb and index finger, and then you can often, follow it all the way down. If you have a hard time finding it, what you can do is look at yourself in the mirror, and if you put pressure on your forehead here with your hand and push your forehead forward into your hand, SCM will stand right up and it will be very easy to see. And so that's an easy way to make it pop up so you can see SCM. But we don't necessarily always want to be seeing SCM on people, because when someone is having a hard time breathing and the SCM is standing up and we can see it, that is a sign of respiratory distress. So when the SCM, the sternocleidomastoid, is working strongly with every inhalation, so the body is really trying to expand those lungs as much as they can, so much so that that the SCM is working hard, that's a sign of respiratory distress. Now, that might be happening right after a workout and you're breathing hard, and that's fine. But if somebody is having an asthma attack, for instance, and you can see their SCM, that's a sign of respiratory distress. And we may need to get them medical attention when that's the case. Or they may need to use their rescue inhaler, or whatever they have and however they treat that. But that is a sign of respiratory distress when you can see the SCM standing up on someone. All right, so that wraps up video 18. So we talked about the diaphragm as the primary breathing muscle. We talked about, can we go back to the diaphragm? Let's see. The diaphragm there as our primary breathing muscle. We talked about accessory breathing muscles, the internal intercostals, the external intercostals. We talked about other accessory breathing muscles. The serratus posterior inferior that helps out with exhalation, serratus posterior superior that helps out with inhalation. We talked about the scalenes that help out with inhalation, so the posterior, anterior, and middle scalene all help out with inhalation. They also do lateral flexion of the neck and flexion of the neck. They also try to pretend they're ligaments if the ligaments of the neck are injured. We talked about the SCM being also an accessory breathing muscle by lifting up on the clavicle and the sternum, but the SCM also protracts the head. It extends and flexes the head and neck, and it does lateral flexion of the neck. And then we talked about this whole hyoid group that doesn't really have quite as much to do with breathing as it does with swallowing and chewing and stuff. So we talked about the suprahyoids, which we really were only able to see mylohyoid and digastricus very well. And then we talked about the infrahyoids, but there are 4 suprahyoids. And we talked about the 4 infrahyoids, omohyoid and sternohyoid, and deep to that is sternothyroid. Oops, where is it? Here, sternothyroid, and oops, wrong one. Oh, I'm not indicating the right one. There we go. Thyrohyoid. Those are our 4 infrahyoid muscles. The hyoids stabilize the hyoid bone, and the hyoid bone is right there. It does not articulate with any part of the skeleton, and therefore it needs that stabilization because the base of the tongue attaches to it. So let's see. What else about the hyoids? They stabilize, the suprahyoids stabilize the hyoid bone from above. The infrahyoids stabilize it from below. So we get this nice, when they're both working, we get this nice stabilization of the hyoid bone. The suprahyoids also depress the mandible. The infrahyoids also participate in flexion of the head and neck when the mandible and the hyoid bone are stable. Okay, that's it for video 18. And I realized that I did not give you a word for video 16 or video 17, and let's just say, let's not worry about it. Okay, great, good job. All right, guys. Next up is video 19, and what is that? Real quick before we go, let's take a look. It is, I know what it is. It's bones of the pelvis. Bones of the pelvis is coming up next. Great. Okay, I'll see you then. Have a good one.